Welcome to the Healthy, Wealthy, and Smart podcast. Each week, we interview the best and brightest in physical therapy, wellness, and entrepreneurship. We give you cutting-edge information you need to live your best life, healthy, wealthy, and smart. The information in this podcast is for entertainment purposes only and should not be used as personalized medical advice. And now, here's your host, Dr. Karen Litzy.
Hey everybody, welcome back to the podcast. I'm your host, Karen Litzy, and in this episode I have the distinct pleasure of sitting down and chatting with two physiotherapists, Mick Hughes and Randall Cooper, about the Melbourne ACL Rehabilitation Guide 2.0. If you're not familiar with Randall or Mick, Randall, who has been on the podcast before, is an experienced sports physiotherapist, founder and CEO of Premax, Adjunct Lecturer at the Trobe University Sport and Exercise Medicine Research Centre, and Fellow of the Australian College of Physiotherapists. As a sports physiotherapist, Randall has worked with some of Australia's most notable sporting organisations, including the Hawthorn Football Club, the Australian Winter Olympic Team, and the Victorian Institute of Sport. He consults from the internationally renowned Olympic Park Sports Medicine Centre in Melbourne. Randall has also attained the title of Specialist Sports Physiotherapist as awarded by the Australian College of Physiotherapists in 2008. Mick Hughes is an experienced physiotherapist and exercise physiologist who consults at the Melbourne Sports Medicine Centre. He is currently completing a Master's of Sports Physiotherapy. Mick has expertise in ACL injury management and ACL injury prevention and has previously worked for elite sporting teams such as the Collingwood Magpies Netball team, Newcastle Jets U20s Soccer team, and NQ Cowboys Under-20s Rugby League team. So it was a great chat on everything and all things ACL. So everyone, have a pen and paper ready to take lots of notes and enjoy this episode. Hi, Randall and Mick. Welcome to the podcast. I should say, Randall, welcome back. And Mick, it's your first time, so thank you for coming on. And Randall, thank you for coming back.
No, it was a great chat we had last time, Karen. So it's great to be back on your show again.
Yeah, thanks for having me, Karen. It's a pleasure to be here.
Yeah, and so today we're going to be talking about the Melbourne ACL Rehab Guide 2.0. So can you guys give the audience a little background on how this came to be?
Well, I'll start off because the 1.0 started about 15 years ago, and it started out of a necessity, really. At the time, I was working with our Australian ski teams and also in AFL football over here. And I was also doing my master's degree in ACL rehabilitation. And we had a horrible couple of years with our skiers where the main team that I looked after was our aerial skiing team, the ones that do the flips in the air and the gymnastics in the air. We had 9 athletes. We had 8 of them do their ACL in 2 years. So we actually had, at one point in time, we only had 2 athletes competing. And back then, this was about 2003, 2004, there was no such thing as ACL or return to sport following ACL reconstruction. And because I had had my head and my attention in the literature, I thought, well, I've got to do something. I've got to get objective about kind of returning these girls back to sport. So I basically put together my own protocol. I borrowed some Hopf Tests that the Noise had written back in 91. I combined it with a few other things and basically put together a protocol that added up to 100 points. And we thought, well, you know, if you need a good mark at university or college, you need to get above about 90 or 95. So we set that as the pass mark. And it just started working, and it worked on a couple of levels. It was nice to integrate the research together and actually have it combined rather than just standalone tests. But the main thing also was it just gave a goal for everyone involved, the athlete, the practitioners, the strength and conditioning people. And the protocol morphed over years and years. It was very low key for the first 4 or 5 years. I basically just used it myself, and tests came and went depending on what the literature said. But after a while, a lot of the, particularly here in Australia, a lot of the people who are working in elite sport started to hear about it, and they said, oh, can I have your protocol? It's like, sure, I'll just shoot it off to them. And after a while, it got a name. And it was in 2013 that I decided I just got to publish it. So I made an ebook and published it, and we've had thousands of downloads. And it just sat there for a while. And after that, after about 4 or 5 years, Mick and I have been colleagues for a long time, and we just kind of got together and said it's probably time for an update. I asked Mick if he'd like to join in and be part of 2.0 because he's really kind of right up to speed on all the research. And he's got such a great profile now that I just thought it was the blend of two great things. So, Mick became involved, and it's been great to have you there.
Yeah, it's been great. It's been great to be involved. And I guess my backstory to coming together with Randall was that I'd moved to Melbourne and knew of Randall for a while. And I moved to Melbourne. I took up a position working with a professional female sporting club. Now that sport's probably a bit unfamiliar to your American listeners, but it's a sport called netball. So think basketball without bouncing the ball. Same goal is to shoot the ball in the hoop. So it's all professional, very athletic females. Now ACL and knee injuries and ankle injuries are very, very common. They take up about 40% of the whole injury profile in netball. Now we had a very small playing list. We only had a list of 10 contracted players, and all of those 10 players were either on the court, so 7 on the court, 3 on the bench. So if one of those players goes down with a season-ending knee injury, you're then tapping into some reserve players who were maybe not quite up to that professional standard, but still very, very good quality players. So I had a very small margin of error. So my goal was to basically prevent as many knee injuries as possible. So I basically thrust myself into the ACL literature, assuming that ACL injury is the sort of the king or queen of all injuries. And if you can prevent one of them, you'll also prevent a few of the other ones that you might come along the way, ankle sprains in particular. So I basically got up to speed very quickly about ACLs, and that's how Randall and I got together to form 2.0. And it's been a great little romance ever since.
And can you guys give... maybe we'll start out with like a quick overview of what it is, of what the guide is and what it entails, and then we'll kind of dig in a little bit deeper. So do you want to just maybe go through the sections quickly, and then we'll dig in?
Yeah, sure. So the protocol is, I'll tell you what it's not to start with. The ACL guide is not a list of exercises. There's plenty of protocols that are out there. They'll say these are the magic exercises for your initial post-op period, and these are your magical kind of exercises in return to sport. We firmly believe that every ACL rehabilitation protocol needs to be individualised, and that clinicians need to take a clinical reasoning approach to that. So it's athlete specific, it's sport specific. But if someone's having trouble regaining strength in their hamstrings, for instance, then you do more work on the hamstrings. If they've got trouble with swelling, then you really need to kind of use a lot of your swelling reduction, anti-inflammatory type of strategies as well. So what the protocol is that it's really just a set of criteria to move through and to help guide both clinicians and also athletes and patients to move through that ACL rehabilitation protocol process with a bunch of very clear, easy to do, criteria-driven outcome measures. And the protocol is split up into 6 phases. So we'll drill down a little bit more into each phase if you like, Karen. But the first phase is a pre-op phase. So that's really ensuring that the athlete or the patient is ready for surgery. Then there's 4 phases of rehab post-op. So there's the post-operative phase. Phase 2 is the strength and neuromuscular phase. Phase 3 is a return to running, impact and change of direction. Phase 4 is the return to sport. And do you know what the phase 5 would be? Injury prevention.
Oh, yeah. Injury prevention. I was like, wait a second. I'm looking at it. I don't see where 5. I see phase 4, return to sport.
Yeah, and it's the reason I asked you that is because it is easily forgotten.
Mm-hmm.
And
clearly,
in a little bit more detail later on, but it's almost the most important phase is to implement an injury or re-injury prevention program as part of the whole process. But that's the protocol in a nutshell.
So when you're talking about prehab in this context, you're speaking of someone who has already had an ACL injury, and they're sort of prehabbing before surgery. How important is that? Huge.
So there's been some really nice papers done, published just recently, and it's probably even stemming back a good 5 or 10 years, but it's very, very clear in the literature that if you are really strong and you've got your strength up to an adequate level prior to your ACL reconstruction, it puts you in a much better place, not just in the first 12 months post-op, but many, many years down the track in a couple of different criteria. So look, there's one of the key papers from ages, like five years ago, clearly showed that if you've got higher KOOS levels, so the subjective questionnaire, the KOOS, if you've got higher KOOS scores leading into the operation, you're going to have better quality of life and better function in the knee up to 6 years down the track. Okay, so it's really important to get that strength and function up before the operation. Now, another really good paper published just recently was showing that if you could do, and this compared, you might be familiar with the Delaware Oslo cohort and the Moon cohort. So basically, the paper by Failer from back in 2016 basically compared the Delaware Oslo group to the Moon group. Now, the Delaware Oslo group did 10 extra sessions of neuromuscular training prior to the operation. The Moon group didn't. So the Moon group got the knee settled and went into the operation. The Delaware Oslo group did 10 extra sessions over 5 weeks of neuromuscular training, strength training, and perturbation training. Now, what happened there? They looked at outcomes over 2 years, and what they found was that those that did those 10 extra sessions, once again, had better knee function 2 years down the track, but they also had higher levels of return to pre-injury sport as well at the 2-year mark. So pretty significant outcome measures there if you get nice and strong before the operation. Now, lastly, why we've added in the pre-op phase is that you can actually get some really good baseline numbers prior to the operation, which a lot of patients don't get. Often patients have their injury, roll up to surgery, and do the rehab. Whereas, once again, a nice paper from last year looked at when you measured strength and Hopf Tests prior to the operation on the uninjured side and use that as your return to sport baseline, 6 months, 12 months, post-op, whatever you want to do, that should be used as the outcome measure to return to sport, not your 6 month post-op score where you've got deconditioned, you've lost strength, you haven't been running, you haven't been jumping. If you're using that outcome measure for your return to sport testing, which is known as the limb symmetry index, if you're using that, you can certainly overestimate someone's ability to return back to sport. So that's why we've included that too, to capture some really nice information. So it's really three-pronged attack as to why we should be doing some really good pre-op.
And if you're the clinician working with someone who just had an ACL tear, and if they're a collegiate athlete or even your recreation athlete, professional athlete, and you tell them, I think we should wait and do some prehab before you go in for surgery.
Yep.
How does one get that across to the patient that, listen, this is really necessary because you may have better outcomes, especially if that person, let's say they are a professional athlete and they just want to get in, they want to have the surgery because they need to get back to sport?
I think, I suppose sometimes this is, both Mick and I are clinicians, so sometimes I think that if you just give them the statistics and the studies, that can kind of whitewash over them, and it's kind of like, so boring, I just want to get going with it. What I tend to use is I will tell them, and I'll reflect on the studies that Mick has kind of mentioned already, but then I think that the most powerful thing is then giving examples of where it's worked with patients in the past and where it hasn't. And going back to my experience all the way back about 15 or 16 years ago, we had an athlete who injured her knee in the Winter Olympics, and it was really quite bad, and it had a lot of media attention around it as well. And she went straight into surgery. She literally injured herself. She was on the plane back to Australia within 12 hours. And within 12 hours of landing back in Melbourne, she was in surgery, and she combined injury. She had an ACL, MCL. She basically blew her knee in half. And it took 6 months to regain her range of motion. It was horrible. Like, it was just so bad. And I think if we'd had those studies that had shown that, that we should have waited 2 or 3, even 2 or 3 months, and she regained her range of motion and got back, she would have actually been ahead at that 6 month point compared to others. So if you can combine a good story, so that resonates kind of like with your athlete or your patient, combine that with the statistics and the research that's out there, you can usually paint a pretty powerful message.
Yeah, that makes sense. And I think maybe putting it into the context of, well, if we can get some range of motion, get your swelling down, and some neuromuscular control ahead of surgery, you'll be that much further ahead out of surgery.
No, that's right. And the other thing to consider also, and this, I don't want to open a can of worms here with conservative versus surgical, but no, there's a lot more people these days who are debating whether, and their patients as well, whether they actually need the surgery.
Yeah.
So in this situation, like if you give them that really good pre-op period where they do their rehab, you get quite a number of them who will really start to question whether they need that ACL reconstruction done kind of during that pre-op phase anyway.
And now, you had mentioned as you were going through the sections of the guideline that you don't give very specific exercises to do within each phase of the guideline. Why is that?
Yeah, no, I think we do. And look, I don't know if that's I don't know. I think my training and Randall's training and maybe some of the training here, and it might differ from country to country, but certainly our level of experience shows that we shouldn't be doing protocols. I think, cookie cutter programs and recipe-based programs is just not an ideal way to go. And we know that, depending on the sport, depending on the age of the person, depending on a lot of different factors, some exercises simply don't suit or are completely irrelevant. So really it should be a really strong, clinically reasoned approach. And the fact is, after a certain period of time, and generally this time is any time after 3 months, a lot of the rehab is really strength and conditioning based, where they should be in a gym doing all sorts of different things, and certainly gearing up to return to sport. Now, every sport demand is also very different too. So the exercises one selects to match the demands of the sport is going to be very different. So like I said, we certainly don't run a dictatorship here of saying you must do this, you must do that, and I think that's not a good way to go. So, and the other reason being is some people just don't love the gym. You could write the best gym program for someone, and they won't do it, and then they'll have a poor outcome because compliance is low. So you need to be able to be very flexible to prescribe exercises that will match the person's enjoyment. So that's why we haven't included any exercises whatsoever. Rather, we've included criteria that people must or should pass between phases of rehab.
Yeah, so you're telling us we kind of have to think a little bit more.
Absolutely, you should think. Don't just be dictated by the orthopedic surgeon's protocol.
Yeah.
Use your head a little bit, yeah.
Yes, exactly, because the demands of, let's say, someone doing a triple hop for the Olympics are going to be much different than the demands of a 16-year-old volleyball player.
Yes.
Right?
Yep, absolutely.
Okay, so it allows you the flexibility to kind of tailor your programs to the person in front of you, which is vitally important.
Yeah, and even, the more sedentary person, someone who's a 40-year-old recreational skier, or even just a recreational runner who unfortunately tore their ACL playing a social sport, running around, they don't need to be doing plyometrics and all that kind of stuff. It'd be nice to do some skipping if they want to run again. But, some of the high-level tasks that they need to perform won't be nearly as tough and demanding as someone who's going to return back to high-level basketball, for example, too. So certainly every ACL reconstructed patient shouldn't be painted with the same brush.
Yes, absolutely. And now, speaking of running, let's talk about that. Running is obviously a big milestone in an ACL rehab. How do we know as clinicians when this athlete is ready to go back to running after their ACL surgery? And is there an ideal time frame for that?
Yeah, it's a really commonly asked question, and we really do have a pretty huge gap in the literature as we speak. There was just a recent review of over 200 papers highlighting that big gap. Like, we know that, there's a certainly lowered risk of re-injuring your ACL or the other side when you return back to sport. But when are they safe to run, or when is it safe to run, or when they should? We don't really know that very well. At the moment, that sort of paper of over 200 papers looked at the time point being the most common indicator, and on average, that time point is 3 months. And in our ACL rehab guide, we've used that sort of 3-month mark, and that's purely based on the biological healing times of the ACL reconstructed ligament. So we certainly don't want to add any extra load to the knee while it's revascularization. So look, we certainly don't have a hard and fast evidence-based approach. There's nothing to say that what we've added here in the protocol is going to lower your risk, but what we've provided is a nice framework of basic strength measures that you should be hitting before you move to those higher demand tasks such as running, jumping, and agility-based work. And if you can't tick those boxes, you're more likely to add more load to the knee, making it swell, making it sore. And I've seen that time and time again. Someone comes into the clinic, it's been 4 months since my operation. I started running because my surgeon said so or my physio said so, but my knee blew up. And I look at their strength, and their strength's so poor, they can't do a single leg rise off a bench. They can't do 5 single leg hamstring bridges. They certainly can't do 10 calf raises. And so their lower limb function on that affected side is so poor that they can't shock absorb when they run. So that's why we've set this criteria that you should be able to hit some nice functional tasks before you contemplate running.
And just to jump in there, Karen, I think also to add to that, I mean, it's the phase 2 kind of assessment basically where we look for people to kind of pass those tests. I won't go through them all now. People can download the guide. It's only a few dollars. So it's easy to see there. There's about a dozen tests to kind of run through, and they're mainly just strength-based. But as Mick said, like there is some concern over whether you're doing any damage to the graft, but it's also about optimizing your rehab, because as Mick said, it's whether the joint gets irritated, gets synovitic, whether you get patellofemoral pain by going back kind of too early. Yeah. These are the things that will slow the rehab down. So kind of timing the running, but also it's not a black and white decision is to say, all right, well, today you're not running and tomorrow you can go back to running 30 miles a week. It has to kind of be a slow blend. But to use that criteria-driven framework so people have that, and it's a nice goal kind of like a third of the way through rehab as well, to kind of say, all right, these are the things that you need to tick off before you can start progressing with your running program as well.
Yeah, and I would imagine making sure that strength and balance and proprioception is adequate is important, because you want to make sure that if someone's running, the forces are distributed evenly through the lower limbs. Because if not, you're going to get stress on that graft, and then you're going to get that angry, irritable knee.
Yep, absolutely.
And so are you also looking at quality of running? So if you're having someone run, you're not just saying, okay, I did all these strength tests, go have at it, go for a run. Are you watching them run in front of you for maybe the first couple of times to look at how the quality of that run?
The short answer is yes. But I mean, it's no different to any other kind of facet of rehab, that the first time that you'll get someone to do a single leg squat as part of their rehab, they're a bit shaky and don't look so great. The first time that you ask them to hop, they're going to be very nervous about it and they won't look so good. And the same happens with running as well. So the way I do it clinically normally is that I will assess them in the clinic first. I like to see that they've come. Sometimes, I have to be honest, sometimes they don't have to tick every single box, but they have to tick most of them. And I also have to look at that kind of gut feeling, clinical kind of, resonance, I suppose, for a better word, is that, yeah, I feel like they're ready as well. And then in the clinic, I'll just spend 5 with them minutes kind of running up and down the corridor, really slow. Let's see how you feel. Not only is kind of like the quality reasonable, but then you can talk to them about what they need to change. And then outline a running program that's specific for them as well. I don't think that you're going to get anyone after an ACL reconstruction who ticks all the boxes and then just can run fluently like Usain Bolt. I think that they'll take a little bit of time to get in it. As a clinician, I think the main thing that you're looking for is that the knee is going to tolerate that load, even if the biomechanics aren't quite perfect, but you're going to work towards getting them perfect over time.
And, you had sort of touched upon a little bit the first time they run, the first time they hop, certainly with single leg, there's going to be some trepidation and anxiety. How are you looking at anxiety in these athletes or in these patients? Because it's obviously after an ACL reconstruction, just like with most surgeries, it goes beyond just the physical. So how are you taking into account that person's mental state and mental readiness as well?
Yeah, no, good question. Yeah, we've got, as part of the criteria, we've got 3 subjective questionnaires or patient-reported outcome measures. So we've got the IKDC, we've got the ACL RSI, and we've got the Tampa kinesiophobia scale, all of which are really nice snapshots of the person's anxiety, confidence, any fears associated with their knee. So that's certainly part of the criteria, and we'll have a look at those as rehab chugs away. And it's a really nice thing. It's a very important thing to do, but it also opens up a conversation, because once you've given the outcome measure to the patient, you can sort of just scroll through the questionnaire and say, okay, you've indicated here you've got a bit of concern, bit of worry. Let's talk about that. And if it's a fear about running, jumping, or landing, then then you can sort of break down their movement patterns. Are they still a bit weak in the quad, or are they just a bit tentative? And if they're just tentative, then it's trying to gradually expose them to those high demand tasks as well. So I think those outcome measures are a really, really important part of the clinical pathway through ACL reconstruction, because it does allow you to sort of break down some of the movement patterns to build up their confidence.
I might just also add to what Mick said, those 3 kind of subjective questionnaires that we used, I think, are really important outcome measures. But the other thing that we use in the second half of the protocol, or the guide, I should say, are our Hopf Tests. Now, when you look at the Hopf Tests, the cut and dry kind of measurement is just distance, but we don't look at quality.
No.
And we've had this discussion a few times before, where you can get somebody whose limb symmetry index looks great when you're comparing left to right, and sometimes even you may compare it to the baseline if you've got great baseline data too. But sometimes you'll look at them and you'll say, it's just not looking the same as the other side. Now, that's hard to quantify as actually on paper. But again, that's where a clinical kind of experience comes into it a little bit as well, to say the hop doesn't, even though they're hopping the same as the other side, it still doesn't look great quality. So why is that? And that's where the clinical reasoning and the clinical art comes back into it. Is it strength? Is it proprioception? Some of these questions can get answered with the tests that are in the protocol, but then is it confidence? Even though they're saying and they're ticking all the boxes on the right boxes, kind of on the Tampa scale, for instance, they still might be bluffing, because they're really desperate to kind of go back. And that's, again, where I think the clinicians need to kind of not kind of be too reliant on the tests and the protocol and the guide, but also look at their patients closely as well to see whether they think that they're happy within themselves to return that person to the next phase or back to sport eventually as well.
Yeah, and once again, probably just building on that a little bit too, it's also observing what the other side's doing too, because we know the contralateral injuries are a huge problem. And there's just been a high-profile case here in our Australian Football League, the AFL, where a player's returned back to sport in his first year back after waiting 18 months, and he's re-injured his other side just a few weeks ago. I actually didn't clear a patient to return to sport recently based on what I was seeing on their other side. A young teenage female who was going back to a high-risk sport was like, well, your operated side's bang on perfect. It's strong, it's confident, you're landing well. But hey, look at your left side. And I filmed her and I showed her and I broke down all her patterns of movement. And I said, I'm not worried about your ACL reconstructed side now. It's your other side I'm worried about. So we need to tidy that up. And this is the kind of stuff we need to work through too. So it's not only observing and looking at the operated side, it's also having a look at the other side too.
And are you using, let's say, those subjective reports of the Tampa and the IKDS ACL, are you using those when you as like your initial intake with that patient and then repeating throughout the rehab process and maybe even into sport, or is it just like a one and done?
I certainly don't do it once. I don't know how much value you'd get out of it within the first few months. It might provide a nice little window of where the person's at, but certainly within that sort of 3 to 9 month, 3 to 12 month window, I'll do it, once every 2 to 3 months, just to sort of see how their confidence is growing and building. It's certainly not a one. It shouldn't be a one-off tick of the box that you do at the 9 month mark, especially when that person's putting their hand up to return back to unrestricted training. And if you only do it at that sort of return to sport, and all of a sudden you capture these questions that say, I'm fearful, I've got concern. If you're only finding that out at the 12 month mark, then you've got another
You're in trouble.
you're in trouble.
Yeah.
You've got another 3 months to try and get rid of those kind of fears, and that person then is going to get cranky at you for holding them back to return back to sport. So I think they should be done fairly every 2 to 3 months throughout the rehab process. Yeah.
Perfect. Yeah, I just wanted to clear that up for people listening who may think, well, I did it once, but I think it's important to know that that's something that should be done throughout the rehab process. Let's talk about your return to sport assessment. It's obviously changed, I'm assuming now, than what it was years ago, Randall, when you first kind of put version 1.0 out to version 2.0. So how has that changed?
There's certain tests that have stayed the same. I mean, I'll take a half step back. The thing that worked really well, as I mentioned earlier, was the 100-point assessment. And we don't actually, the frustrating thing is that we don't have a clear kind of pass mark for it either. Again, a lot of it comes down to the clinician and making sure that they're happy with the numbers and happy within themselves. But the tests have morphed a little bit. In version 1.0, we had the star excursion balance test, we had the single hop test, we had the triple crossover hop test, we had single leg squats to fatigue, or the single leg rise test, and we also used the landing error scoring system, which in recent years has shown to be not really all that kind of great for a return to sport, kind of prevention of re-injury type stuff anyway. So we've changed it a bit. There's more hop tests. Yeah. So we've added in another 2 hop tests.
Yeah. So we've got the triple hop, the straight line triple hop, and we've also got the side hop as well, which I like. I think they're nice additions to the program. So the single, the triple straight, and the triple crossover certainly form a really strong evidence base, which have been used in 2 recent papers looking at knee re-injuries, ACL and other types of knee re-injuries in the first couple of years. But also too, the side hop is I like it in particular because it's an endurance-based test, and you can start to see quality issues creep in, especially with someone that's fatigued on both sides of the body. So that's one of the new ones we've certainly added in, which we're really excited about.
We've also, a couple of the other things that we've added in, probably the main one is also testing in a state of fatigue. So,
and why is that important?
Injury, ACL injury in the first place, that fatigue plays a factor. That's been known for a while. The second thing is that it's also been shown with recent studies that the limb symmetry index can change dramatically when people are tested in a fatigue state. So they may have 90% limb symmetry index, which has kind of been the benchmark for a while when they're tested fresh. But when they're in a fatigue state, you can see that limb symmetry index between left and right changes significantly. So Mick and I thought that it was a very pertinent time to kind of pop in some hop testing and some other tests in a fatigue state. We've also combined that with some fitness measures as well, because your fitness level is a huge part of injury in the first instance, and also injury prevention in the second instance. So we've got basically the return to sport test has now been divided into 2 parts. The first is the hop test battery, the star excursion balance test, the single leg rise test, a couple of other things in there as well. But then also to do another testing session in a fatigue state where the athletes do 2 fitness measures, and that's compared against a baseline. And then after that, once they've got to a VAS of 7 out of 10 fatigue, then they repeat some of these hop tests as well to see whether they're starting to get that disparity with their hop tests too. Because that's a concern for people going back, that they may look good on paper, but once they're really tired, they may have some strength endurance issues, and that's what we've tried to reflect in the testing and the protocol now.
Yeah, I saw a nice little case study snapshot yesterday on Instagram. If you follow the Prehab guys, they've got on their Instagram My Stories, they put our ACL rehab guide to test on one of their patients, and they tested that patient in a fatigue state, and his scores were significantly lower in that fatigue state. So that was a nice little case study there, which people can see. But yeah, it's an important part. We should be preparing. I think this is the big thing. Like when a person wants to go back to sport, we we need to make sure they're best prepared to go back to sport and be able to resist fatigue. And certainly setting that patient up and preparing them for the worst case scenario when they return back to sport is very important. We don't want to sort of overestimate their ability to go back to sport based on outcome measures that are tested in a fresh state, because that's not necessarily when you're going to injure your ACL. You might injure that there's been some links to injuring your ACL in the first quarter of a game or the first few minutes of a match due to ineffective warm-up. But a lot of the injuries that we tend to see is sort of more that fatigue-based injury where the person just can't withstand those forces any longer. Very important to do that return to sport testing in a fatigue state.
And when we're talking return to sport, can you define what return to sport is? So when you're talking return to sport and you're at the point where you're doing this testing, they're already doing components of their sport. Am I correct in saying that? So they're already, if let's say it's a soccer player, a football player, they may be already out on the field doing some components of the sport before you do this sort of return to sport assessment. Let's say they're a more higher level athlete, right? So when you're doing these return to sport tests, are they return to participation? Is it sport? Is it performance? How do you delineate that? And do you?
Yeah, it's a pretty complex question. And
I feel like that could be a podcast in and of itself, but.
100%. Look, I think you're right in that, the return to sport testing, certainly the patient should be doing some field, if they're a soccer player, for example, before they do that return to sport testing, there's no doubt they're going to be doing some aspects of their skill-based training. And look, if they're running, jumping and doing agility prior to all that, of course, they can and should be doing some degrees of training, whether or not they're unrestricted training. I think that's a big one. So in that Recurrences study back in 2016 that looked at ACL re-injury rates, their return to sport discharge criteria was based on once they hit that 90% limb symmetry on the strength and Hopf test, they were cleared to return to unrestricted training. So that's kind of, I guess, where people should be taking these measures and applying it. So certainly before that, if they're just building up strength and they're working up to that return to sport goal, it should be considered return to unrestricted training. Because then performance and eventual return to sport and then return to previous performance are two very, very different things.
Sure.
And in my experience, and Randall probably's got other experiences too, I feel like a person needs at least 1 month, if not more, of unrestricted training to even get them close to the same level of speed and performance and agility and touch and all these kind of finer points of skill-based sport before they even get considered to return back to play and be named in the starting 10 or 15 or whatever sport you're playing. And that's been my approach in the past with ACL reconstructed patients, is that they must have at least a month of training and must play at least a couple of rounds of lower level play before they go back to their pre-injury levels of sport. So that still is a good 6-week process, that once you get the green light to go back to sport, it's not an automatic go back to sport. It's a process.
I think I just might add to that. In the term return to sport's almost a bit silly, isn't it? Because
it's not so clearly defined.
No, that's right. Because you could say, running 3 miles or 5 kilometres every week is returning to some kind of sports, right? So I think that the best term, and we haven't used it in the protocol because I don't want to be that controversial, but I think the best term is return to high risk, right? So like when it comes to kind of like, let's use soccer, European football as kind of like the example. When those players get back to starting to do competitive drills where they're really cutting hard, they're doing unconscious change of direction, they're getting tackled, they're in gameplay kind of situations, for me, that's return to sport. So that they need to have kind of qualified all the criteria, because that's high risk. Whereas running cones, doing sprinting, doing kind of conscious kind of drills, just joining in a little bit of light training here and there, that's part of the process. So I think it depends on the sport. It depends on the clinician. But my take-home message for most people would be to run the return to sport test as a return to high risk test.
Yeah, because I think it's important for the listeners to know that when you're doing these return to sport tests, if you're it's not like they haven't been doing anything out on the field or out on the court, and then all of a sudden you're going to do this and say, okay, have fun, go ahead and return to your sport. Like, they are already training with restrictions that maybe you've placed on them, whether that restriction be time or whether it's no cutting or whether it's whatever those restrictions may be for the sport. But I think it's important to know that they're already working at that level. You're going to, like you said, clear them for full return to risk or performance. They might not even get to performance the first time you clear them. I can't imagine that they do.
Performance is a 12-month to 18-month process.
Yeah.
Some of the studies on NBA basketball players, NFL players, some of them, NFL players sometimes don't even come close back to their previous levels of performance. NBA players, some studies looking at, you might get to the same level of performance 2 years after they return back to sport.
Right.
So performance is such an evolution in the process, but return back to high-risk sport, high-risk activities certainly is the first tick of the box.
Yeah, and so I think that then takes me to my next question, which you set it up perfectly, is once you've returned to sport after an ACL reconstruction, are we done?
In some ways, I think that on a personal level for that athlete, there needs to be some level of celebration because it's a long process. Like Nick and I were just talking before we went on this podcast about how quick people can get back, but it's going to be somewhere between, if you're absolutely flying and have to push it, 6 months, but sometimes you're not returning people back to sport for 18 to 24 months kind of post-op. So for them to kind of get back is a big milestone. And, it usually requires a lot of hard work on everyone's behalf. So I think that at that point in time, it's kind of a nice point in time to say, well done. But unfortunately, the job's not done because the re-injury rates for people who have had an ACL injury are high. The pooled statistics is that you've got a 5% chance of redoing the same knee. You've actually got 11% chance of doing the other knee. So you're actually more likely to do your ACL than what you were before you had the ACL in the first place. Mm-hmm. So then kind of going on and doing an injury prevention program is really important. There's not a lot of research around injury prevention programs for re-injury of the graft. There's plenty of research around there to show that if you do an injury prevention program to prevent an ACL in a primary and initial first ACL injury, then that can be highly effective, 50% reduction in the injury rates. Mm-hmm. So I think there's a body of work there to still kind of do, but it's very important that for two things. I think the first is that they need to continue on with some level of ACL injury prevention program, whether that's an off-the-shelf thing like the 11 Plus or the netball knee. There's 5 or 6 of them. We've got them listed in the guide as well. Or whether it's tailored a little bit with the team and the strength and conditioning coach. So I think that's really important. The other thing also is that there may be a role to have those athletes monitored as well. No different to the way, I know you've spoken to people about groin injuries and kind of, doing squeeze tests and strength tests to make sure that their adductor strength is staying up to scratch. I think in our area, which is ACLs, if people can maintain good hopping symmetry, good mechanics, strength, and also then comparing it. The thing is great, if you go through the protocol, you go through the guide and you've got all those outcome measures that are there sitting, waiting, and can be used, then you can kind of compare that 6 months down the track, 12 months down the track, 24 months down the track, if they're still in that same sport. I think there's no evidence for me to back up what I'm saying here, but I think it makes the logical progression kind of like in the way things are heading. Yeah,
absolutely. And I think like what Randall said is certainly when you get back to sport, it should be celebrated. But and certainly there needs to be some ownership on the patient that they've now just naturally through their original injury, they've just now got an elevated risk. So it sort of needs to have some ownership taken on board that once they go back to sport, it's just not all done and forgotten about. I think it's like brushing your teeth. These patients should be sort of waking up every morning without being, consciously thinking I've got to do my injury prevention program. It should be just accepted that they, for the rest of their playing career, they commit to 2 to 3 strengthening sessions per week. A good professional club will also have those nice dynamic warm-up activities performed each and every training session, each and every game. So already they're putting themselves in that nice position. They've got a lower risk. But I think those regular monitoring and touching base with the physio staff medical staff within the club. I think that's an important thing. So whether or not that's a once every 6 month screening process where you look at your strength and Hopf tests, make sure things aren't dropping. But importantly, looking at the quality of the movement over time and making sure that hasn't slipped. Because I think as soon as you start thinking that you're good to go and things are great, I think that's when you can start drifting back into those old patterns of movement that led to that first injury that happened in the first place. So it's more about that quality control over time.
And is the physio the person who is kind of making these decisions? So they're the ones doing this sort of the return to sport decisions, return to participation, performance, and also taking the lead on a lot of this follow-up care.
Oh, that's a really tough question, and I don't know how it is in the States and in Europe so much, but it's a controversial question here as well, because there's physios who will do it. There's strength and conditioning people who feel that's their role. Exercise physiologists. I don't know. I don't know who. No, I'll say it differently. I don't think there is a best person or a best professional to kind of do these tests as long as they're done. So as long as I think that these things are monitored, and then wherever the strength in that athlete's setup is, i.e. they've got a great relationship with their physio or they're working very closely with their strength and conditioning kind of team, I think as long as those things are done, and then if there's problems arise, then the right people are brought in to kind of correct those errors. That's the way I'd play it. What about you, Mick?
Yeah, no, I agree. I think, well, certainly here in Australia, I think physios are often seen as that person that does drive a lot of the ACL rehab. But there's certainly a teamwork approach. I certainly work closely, even clinically now, even though I'm not with the team anymore. I certainly refer on to appropriately trained exercise physiologists or strength and conditioning coaches, just to get that quality rehab in. My time is a bit restricted here in the clinic, and our facilities are a bit restricted. We don't have the luxury of having a 20-meter running track or, soccer goalpost to sort of kick and do.
Listen, I'm in New York. I get that.
Yeah.
The space is not there.
Yeah, so I think physios are often seen as that person, that go-to person for ACL rehab, whereas really it should be a team-based approach, and a network of good strength and conditioning coaches or exercise physiologists or exercise professionals is a really important person to be consulting with throughout that whole rehab process. Now, that final return to sport testing, it's one of those things. As long as it's done, I think that's the key thing. Because some orthopedic surgeons might feel comfortable doing that. They might take a bit more ownership on the whole patient themselves. But I know a lot of surgeons here in Australia often don't have the time nor space to do that adequately either. But as long as those tests are being done and they're being analysed and critically and analysed for quality of movement, I think that's the key thing. Yeah.
All right. So now, before we kind of wind things up here, is there anything that we missed or anything that, you want to add on to this conversation?
Well, not for me. I think that, again, just kind of going back to the essence of the Melbourne ACL Rehabilitation Guide. I mean, again, we don't think that a prescribed exercise program is the way to go. We really feel, and I think this has been reflected in our conversation over the last 45 minutes or so, is that there's so many things to address and factor in someone's, and having an individualised kind of approach to rehab. And that's really what we want reflected kind of in ACL rehab generally. And the protocol is really just the bones to really help drive that process along. But there's so much to it.
Yeah, I think that one of the key take-home messages for me is that, time is a really poor indicator for future success. This whole time-based system of when a person has their operation and then gets cleared to return to sport based purely on time is just almost a recipe for disaster. And, classically we see this 12-month mark as that return to sport. Now, you could just cruise through your rehab and put in a really crappy rehab and get to 12 months and expect to go back to sport. I think the whole rehab process needs to be criteria driven all the way from when you start running through to return to high risk activities to eventually return to sport and then eventually into ongoing injury prevention. I think it certainly needs to be criteria driven rather than a time-based approach. That's my key take home message I'd like to share.
Great. And then one last question, and sorry, I forgot to give this to you before we started, but it's a question that I ask everyone kind of at the end of the podcast. And that's, given what you know now and where you are in your career and in your life, what advice would you give to yourself as a new grad? So not advice you would give to someone else, but what would you tell your younger self?
You can go first, Mick.
Yeah.
Way to pass the buck.
yeah, that's a really good question. Yes, if I went back to my new grad self, I'd say be patient and certainly don't think you can fix everyone. Every person that walks in the door, know that they run a different race, and not every patient will achieve these fantastic outcomes that everyone's back pain-free and function-free and don't re-injure themselves ever again. Expect that there might be some injury reoccurrences and some failures, and I experienced that last year. We had an ACL reconstructed patient who returned back to netball in that season, and unfortunately she did her contralateral side at the end of the season, and that was, to me, that was a big eye-opener. She passed all the tests, she did everything right, and we were doing everything well, and I took that quite personally, that I'd sort of didn't do. And even still 12 months later, I think you're still
a little upset.
It's just one of those, it's absolutely one of those things that I think you sort of need to be kind to yourself when things don't go to plan. And I think that's important as a new grad, that you won't fix everyone and you can't fix everyone, but you can do your best. And as long as you sort of do your best, you can sleep well at night.
Yeah.
My tip to my younger self, I'll reflect on when I was a young physio, was that I was so keen to just learn all I could, and I went to every single course I could and every single lecture I could, which was great, but I probably did too many things too quickly, and my education was accelerated too far ahead of my clinical experience. So I'd go along to a lot of these courses and I had no idea what they were talking about, because I just hadn't kind of experienced it in the clinic as well. So my tip is similar to Mick, and that is that take your time, make sure that you're kind of getting your hands on people, you're getting that clinical experience, and then that dovetails in with kind of like your further education, so it makes sense to you at the time.
Great advice. Excellent from both of you. Thank you so much. And just so all the listeners know, we'll have a link where you can download the Melbourne ACL Guide 2.0. That'll be in the show notes at podcast.healthywealthysmart.com under this episode. So no worries. You can download that immediately with one click. So thank you, Randall. Thank you, Mick, for taking the time out 14 hours ahead of me in New York. You guys are in Melbourne. So thanks so much.
Thanks, Karen. Thanks for having us.
It's been a pleasure, Karen. Thanks for having us.
Yeah, anytime. And everyone, thanks so much for listening. Have a great couple of days and stay healthy, wealthy, and smart.
Thank you for listening, and please subscribe to the podcast at podcast.healthywealthysmart.com. And don't forget to follow us on social media.